In this lecture, I am going to discuss trachoma with its pathogenesis, diagnosis, and management. Starting with pathogenesis, trachoma is the world's leading cause of preventable, irreversible blindness. It is related to poverty, overcrowding, and poor hygiene. The morbidity being a consequence of establishment of reinfection cycles within communities. Whereas an isolated episode of trachomatous conjunctivitis may be related to innocuous recurrent infection, elicits a chronic immune response consisting of a cell-mediated delayed hypersensitivity reaction, type 4 hypersensitivity reaction, to the intermittent presence of chlamydial antigen and can lead to loss of sight. Prior contact with the organism confers short-term partial immunity but also leads to a heightened inflammatory reaction upon reinfection. Vaccination has an effect similar to primary infection in sensitizing the individual and as a consequence is not helpful. The family child care group is the most important reinfection reservoir and young children are particularly vulnerable. The fly is an important vector, but there may be direct transmission from eye or nasal discharge. Trachoma is associated principally with infection by serological variants A, B, BA, and C of Chlamydia trachomatis, but the serovariants D to K conventionally associated with adult inclusion conjunctivitis and other species of Chlamydia families such as Chlamydia uh, psittaci and Chlamydophila pneumoniae has also been implicated. Features of trachoma are divided into an active inflammatory stage and a cicatricial chronic stage with considerable overlap. Active trachoma is most common in preschool children and is characterized by mixed follicular or papillary conjunctivitis, as it is shown in the first picture. Uh, these seem like follicles as the vessels are going around them, and these are the vessels going around them, uh, but there are some papillae here in between, and they are associated with a mucopurulent discharge. In children under the age of 2 years, papillary component may predominate. Superior epithelial keratitis and pannus formation, as it is shown here, the pannus is very evident, and this might lead to keratitis as well. The next stage is the cicatricial trachoma, which is prevalent in middle age. Linear or stellate conjunctival scars in mild cases or broad confluent scars outline in severe disease is seen. Uh, you can see stellate conjunctival scars as the arrow is pointed out here, and here the arch line is very prominently shown in the figure. Effects are more prominent on the upper tarsal plate, even though all conjunctiva might be involved. Superior limbal follicles may resolve to leave a row of shallow depressions called Herbert's pit, as you can see here, here, and here. Trichiasis, distichiasis, corneal vascularization, and cicatricial entropion can be seen, as you can see here. The hair follicles are grown inside, and this can lead to keratitis and very uncomfortable situations. Severe corneal opacification, that is the result of trichiasis. Dry eye is caused by destruction of goblet cells in the ductules of the lacrimal glands. A WHO grading system for diagnosis is also in use, which includes 5 characteristics. The first one is trichomatous inflammation, which is follicular. 5 or more follicles, more than 0.5 millimeter on the superior tarsal plate. Then trichomatous inflammation, which is intense, diffuse involvement of the tarsal conjunctiva, obscuring 50% or more of the normal deep tarsal vessels. Papillae are present. Then trichomatous conjunctival scarring, easily visible fibrous white tarsal bands. Then comes the trichomatous trichiasis, at least one lash touching the globe. And in the end, corneal opacity, sufficient to blur details of at least part of the pupillary margin. The whole thing makes a mnemonic of FISTO, or F stands for follicular conjunctivitis, I for inflammation, S for conjunctival scarring, T for trichiasis, and O for corneal opacity. Most important part is the management. The safe strategy for trachoma management, supported by WHO and other agencies, encompasses S for surgery, E for antibiotics, inactive disease, facial hygiene, and environmental improvements. Antibiotics should be administered to those affected and to all family members. A single antibiotic course is not always effective in eliminating infection in an individual, and communities may need to receive annual treatment to suppress infection. A single dose of azithromycin 20 mg per kilogram up to 1 gram is the treatment of choice. Erythromycin 500 mg twice daily for 14 days, or doxycycline 100 mg twice daily for 10 days. Tetracycline, however, are relatively contraindicated in pregnancy, breastfeeding, and in children under 12 years of age because of risk of tooth staining. Topical 1% tetracycline ointment is less effective than oral treatment. Facial cleanliness is a critical preventative measure. Environmental improvements such as access to adequate water and sanitation, as well as control of flies, is important. Surgery is aimed at relieving entropion and trichiasis and maintaining complete lid closure, principally with bilamellar tarsal rotation. Now here we come to the end of this lecture. If you like the lecture, please press on the like button and subscribe to the channel. Thank you all.